PG seminar. I request our President, Dr. Sandeep Trivedi, to welcome one and all.
Thank you, Prashant. This is the dream project of our NNF Gujarat State Branch, and also project coordinator Dr. Yogesh Parikh, and I welcome Dr. Somsekhar sir and Ashish Mehta sir. And I welcome Dr. Anuj, who is the chairperson of today's sessions, and Dr. Amit Upadhyay and Anand Vindekar sir, and today presenter Dr. Tejal. I welcome all of you. This program is very helpful for the neonatal, those who are going to do neonatal practice, and also PG student also, and also pediatrician. Thank you very much.
Thank you, Sandeep bhai. So without taking much of a time, I introduce today's chairperson, Dr. Anuj Grover. He is a consultant neonatologist and director at Setu Newborn Care Center, trained at BJMC New Civil Hospital, Ahmedabad. He is having a 12 years of experience in neonatology from the UK and trained in tertiary care unit over there. So we welcome our today's chairperson, Dr. Anuj Grover, sir. Please start the beginning, sir.
Thank you very much, Prashant. Thanks for having me as the chairperson today. The topic today we have is a very interesting one, retinopathy of prematurity, and we have stalwarts of from India, both in neonatology and ophthalmology as part of this session. So it's a pleasure for me to be part of this. The session will begin with Dr. Tejal presenting a seminar on retinopathy of prematurity. And we have our two experts, Dr. Anand Vindekar sir and Dr. Amit Upadhyay sir. Just to give a brief introduction of all the speakers, Dr. Tejal has done an MD and is currently pursuing a fellowship at Urban Newborn Care Center at Ahmedabad. She's doing her neonatal fellowship here. Dr. Anand Vindekar sir actually doesn't need the introduction to this group, but he's a very senior consultant ophthalmologist devoted entirely to ROP, multiple awards. If I can, he's the head of Department of Pediatric Retina in the Narayana Nethralaya Eye Institute, Bangalore, and Program Director of the Kid Drop, which is the tele-ROP set up in Karnataka. Is a member of the Task Force of ROP, Government of India, Founder Secretary of Indian ROP Society. Anand sir has had multiple memberships in various international ophthalmology guidelines, over 100 publications. He's had fellowship in pediatric retina from US and PhD in ROP from Netherlands. We are privileged to have you here, sir. Thank you so much for being part of this session. We also have Dr. Amit Upadhyay. Again, most of the neonatologists in this group are very well aware of Dr. Amit Upadhyay. He's done MD and DM neonatology from AIMS New Delhi. He's done fellowship neonatology from Monash in Australia, former HOD of pediatrics from Medical College in Meerut, and currently Dr. Amit is the director of Nitema Hospital, Meerut, and in charge of the level 3B and ICU. He's been organizing secretary of IAP Neocon 2014, UP Neocon, academic coordinators of UP Neocon 2018, and Central Zone UP Neocon 2021, national examiner in MD and DM exams. Very warm welcome to you, sir. I would like to ask Tejal to now take over and start her session, please. Tejal, are you there?
Yes, sir. Yes, sir, I'm there.
Okay.
I'm just sharing the slide.
Is Tejal visible on the screen? Is her video visible?
She is not visible in her slides are not visible. Tejal, just to save the times because we are running 10 minutes late, I'm presenting. You can just start. Tejal?
Yes, sir.
Yeah.
Okay.
Yes, Tejal, start please.
Yes, sir.
Previous slide. No, okay. Previous slide.
Previous slide. Good afternoon, everyone. I'm Dr. Tejal Odedara, presenting seminar on the retinopathy of prematurity. Next slide. Overview of ROP. ROP is emerging as one of the leading cause of preventable childhood blindness in India. It is a vasoproliferative disorder of retina, which occur in preterm infants. A significant morbidity in extremely immature infants whose survival rate continues to increase. Outcomes spectrum. It can be minimal sequelae with no effect on vision in milder cases, or it can be bilateral irreversible total blindness in advanced cases. Next slide, please. In India, disease was first reported in 1990s and currently increased to the epidemic proportion being reported. In 2015, there was a landmark judgment from Supreme Court of India ordering to be paid to a family of an infant who had gone blind from stage 5 ROP, set a cascade of clinical, operational and the legal action. Every 2 or 3 infants reach threshold for the treatment in India. Now the risk factors: prematurity, low birth weight, small for gestational age, RDS, postnatal nutrition, and poor postnatal weight gain. Blood product transfusion, sepsis, severe intraventricular hemorrhage, PDA, and early use of the erythropoiesis stimulating agents. Now the classification, which was given by international classification of ROP, which divide classification into 3 types: location, extent, and the severity. So according to the location, it divide retina into 3 zones. Zone 1 is the imaginary circle, which is a radius double to distance from the optic nerve to the macula. Zone 2 is edge of the zone 1 to ora serrata on nasal side and half distance to the ora serrata on the temporal side. And the zone 3 is a outer crescentic shape area from the ora serrata. Now according to severity, there are 5 stages. Stage 1, in which there is a development of demarcation line which is separating vascular retina from the avascular retina. Then in stage 2, there is a ridge formation, which is addition of the depth and the width to the demarcation line. Stage 3, then extra retinal fibrovascular proliferation, which extend from the ridge to the vitreous. Stage 4A, there is a partial retinal detachment not involving macula, and stage 4B, there is a partial retinal detachment involving macula, and the last stage is stage 5, complete retinal detachment. According to extent, refers to the circumferential location of the disease, and if reported as a cloak hours in the appropriate zone. So it divide according to the 3, 9, 12 hours. Then plus disease. This is the additional classification, which is presence of the vascular dilatation and the tortuosity of the posterior retinal vessels in at least 2 quadrants. May also associated with the iris vascular engorgement, pupillary rigidity, and vitreous hairs. There is a pre-plus disease. Vascular abnormalities of the posterior pole, mild venous dilatation or arterial tortuosity that are present but are insufficient for the diagnosis of the plus disease. Then one more important form of ROP, which is aggressive posterior ROP, which occur to the extreme premature neonates, occurs earlier, below in less than 3 weeks. It is a most aggressive form of the ROP. Posterior in location, zone 1, zone 2, posterior. Mostly seen without classical ridge, characterized by the ischemic loop, capillary non-perfusion, and flat intra-retinal network neovascularization. It is very rapidly progressive, and it leads to the retinal detachment. Now the screening. which is one of the most important domain for the pediatrician, because there is no visible extraocular signs and symptoms. So timely and regular retinal examination is required. For the screening purpose, mostly using 3 guidelines, which is National Project Operational Guideline for the ROP 2018, RBSK 2015 guideline, and Clinical Practice Guideline 2019 by NNF, widely used. Now, first screening at 32 weeks of the postmenstrual age or 4 weeks of the postnatal age, whichever is later. For less than 28 weeks or the birth weight is about 1200 gram, screen at 3 weeks of postnatal age to detect AP-ROP. Now, ROP screening can be terminated when complete vascularization of the retina without any ROP, or ROP has shown regression, or this normally happens at around 40 to 44 weeks of the postmenstrual age. Usually ROP doesn't develop before 2 to 3 weeks. Median age at detection of the ROP stage 1 is 34 weeks. It reaches to threshold of ROP around 34 to 38 weeks. Now, whom to screen. If gestational age is known, then 34-weeker neonate or less than that. If gestational age is not known or unsure, all infants less than 2000 gram birth weight should be screened. Preterm infant with gestational age more than 34 weeks but has a risk factor should be screened. When to screen? Before discharge from the NICU or 30 days of the life, whichever is earlier. Now, screening methods: indirect ophthalmoscopy by trained ophthalmologist, or retinal image using a wide retinal camera, which is a Netra Neo or RedCam by trained ophthalmologist, or can be used by trained technician, DEIC, optometrist. Where to screen? Admitted newborns if NICU or SNCU unit. Then if infant is discharged, then NICU, SNCU or ophthalmologist clinic. Decision at each screening, we can widely divide into three sections. Whether child required no further screening, if retinal vessels are mature in both eyes or the ROP has spontaneously regressed. Further follow-up if immature retina or any stage ROP not requiring treatment, or urgent treatment required. Now, preparation: pupil dilatation or tropicamide 0.5% to 1% with phenylephrine 2.5% 30 minutes prior to the examination. It can be combined with topical application of the eye drops of proparacaine 30 seconds prior to examination with 24% sucrose or 25% dextrose orally 0.5 ml per kg for the prevention of the pain. NNS or the single-use pacifier can be offered. Now, models for the ROP, screening of the ROP. There are widely acceptable model is the indirect ophthalmoscopy, which is cheap and direct doctor-patient contact is there, but it has limitation like time. It is time consuming, dependent on the ophthalmologist. The another model is using wide field camera, which can be used by paramedical staff. It has a high, it can cover the more number of the patient, and the process is very fast, but the equipment is very expensive and there is no doctor-patient relationship. Another benefit of the wide field camera is we can photo document the disease that we can use for the teaching and counseling tools. Another model is smartphone based screening, which is cheap photo documentation is there, but ophthalmologist dependent. This is a picture of RedCam, which is quite bulky, and another is Neo Forest from India, which is lighter. Now, after screening, we can divide and give the follow-up of the patient according to this chart. It divide according to the zones. If zone 1 is involved, the stage is immature, then 1 to 2 week follow-up should be given. Stage 1, 2 or regressing ROP in zone 1, 1 week or earlier. Then stage 3, AP-ROP in zone 1 should be treated. And if ROP findings are there in zone 2, if it is immature, then 2 to 3 weeks follow-up should be given. Stage 1 in zone 2, 2 weeks follow-up should be given. Stage 2, regressing ROP, if with plus disease, then should be treated. If not, follow-up 1 to 2 weeks after. And then stage 3 in zone 2. If plus disease is there, then treat it. If not, follow-up 1 week or earlier. Then zone 3, stage 1 and 2 or regressing ROP, 2 to 3 weeks follow-up should be given. Post anti-VEGF, long-term follow-up needed, may need laser treatment if recurrence or the persistence of the avascularity. Now the treatment. Whom to treat? Developing signs of sight-threatening ROP in one or both eyes. When to treat? Within 48 hours of the diagnosis, type 1 ROP, AP-ROP or the hybrid ROP. Who should treat? Ophthalmologist who is trained and competent to treat sight-threatening ROP. Where to treat? In SNCU, NSU if an inpatient and discharge infant in eye department. Now treatment criteria which is given by ET-ROP, which is early treatment ROP. It divide into two type of the ROP. Type 1 in which there is a urgent treatment required, and type 2 there is a need to close follow-up. So in type 1 there are zone which include zone 1 any stage ROP with plus disease, zone 2 stage 3 ROP without plus disease, zone 3 stage 2 or 3 ROP with plus disease, and if there is AP-ROP in any zone, it also included. Then type 2 where the close follow-up needed, zone 1 stage 1 or zone 1 stage 1 or 2 ROP without plus disease excluding AP-ROP, and zone 2 stage 3 ROP without plus disease excluding AP-ROP. Now treatment. Retinal ablation. First, previously it was used cryotherapy, but nowadays we are not using it frequently. The second one is laser, which is gold standard. Anti-VEGF, sclera buckling, vitrectomy, which is lens sparing, and with lensectomy. Now mode of the treatment. First is laser therapy. Laser therapy is gold standard and preferred, delivered by the indirect ophthalmoscope and applied to the avascular retina. Previously, diode laser was using, but which is replaced by 532 nanometer green laser. Treatment must be performed in less than 48 hours of the diagnosis, performed under oral sweet agents, topical anesthesia, or sometimes under GA. Side effect of laser therapy are cataract, glaucoma, or anterior segment ischemia. Anti-VEGF therapy, it mostly used in rescue cases, mostly in posterior zone 1 or AP-ROP. Intravitreal bevacizumab for type 1 ROP involving zone 1. Should not use for the treatment of zone 2 ROP. Now benefit of anti-VEGF therapy are less stress to the infant, require less heal, less destruction of the retina, and low risk of myopia. The concern regarding anti-VEGF therapy are systemic absorption, reduced VEGF and vascularization of other organs, and in anti-VEGF therapy requires 60 follow-up up to 65 weeks of the PMA. Recurrence common in type 2 ROP, and monitor supplement therapy with the laser, refractive error, squint, delayed onset retinal detachment. Long-term follow-up for the development issue of other organ system. Now, mostly in market, bevacizumab, which is Avastin, is available and frequently used, which is cheap, but there is neurodevelopmental issues and late recurrence in 12 to 14 weeks. Another one is ranibizumab, brand name is Lucentis. which is expensive, high-end, early recurrence, 4 to 5 weeks. And ILIA, which is very expensive but longer lasting effect, recurrence rate is unknown. Now, in retinal detachment stage, surgery is required for the stage 4B and 5 ROP in attempt to reattach retina, vitrectomy with or without lancectomy and membrane peeling. Remove traction force causing retinal detachment, but poor prognosis is there. Scleral buckling for more peripheral detachments are nowadays using. Now, follow-up after treatment, ophthalmologist should follow up at 1 week. Further, if there is further laser requirement, may require long-term follow-up. Infant treated for sight-threatening ROP and at high risk of refractive error and other eye conditions, they should be followed up until at least 5 years of the age. Now, for the prevention. Antenatal steroid is one of the most important preventive factor. Another is the restrict use of the oxygen. Use CPAP when required. Early enteral nutrition, breast milk preferred, and the aggressive nutritional therapy. Follow aseptic precaution to prevent sepsis and restrictive blood transfusion policy. Now, recent modalities under trial and studies. One is ROP has now started to be considered as the biomarker of the brain development. And cord blood transfusion to develop blood component contain cord blood derived erythrocyte for the transfusion. Association of the ROP and low level of the actinoid acid. Prevent low platelet counts to prevent ROP. Another important one is low weight gain, which is less than 50% of the birth weight in the first 6 weeks, being considered superior to birth weight and gestational age alone as a predictor for the severe ROP. New anti-VEGF also under trial. Pegapeptinib and the aflibercept are also under trial. Propranolol study also there, which has anti-angiogenic action, which decrease VEGF overproduction in hypoxic retina. More studies for the safety issue should be there. IGF, aggressive parenteral nutrition versus conservative nutrition. GCSF, omega-3 polyunsaturated fatty acid, gene therapy are some promising modality under trial. For the screening purpose, smartphone-based camera, low cost and non-contact. One study is there. It has no non-contact but limited field of view. This is nowadays promising screening modality, which is telemedicine. In India, 3.5 million preterm births are there, and around 200 ROP experts are there. And majority ROP centers are in urban areas. So for the screening of the patient from the periphery, this telemedicine model is now under trial. In this, there is from the different side of the NICU, all the data collected, and then it transferred to the ophthalmologist, which screen the data, and it they give the diagnosis, and it again deliver back to the NICU side from, and give the very good promising future aspect for the screening purpose. Now, studies and trials which has been done for the ROP. One trial is WIN ROP, weekly measurement of the IGF, and weekly weight from the birth until 36 weeks. Correctly identify all infants with high risk ROP and those requiring laser treatment. Insulin-like growth factor 1 alone. IGF-1 serum level in 3rd week postpartum is good prognostic tool to identify high-risk babies of developing ROP. One more trial is BEAT ROP. Bevacizumab eliminated the angiogenic threat of ROP, comparing anti-VEGF versus conventional laser. It suggests superiority in anti-VEGF treatment over conventional laser therapy for stage 3 and plus. Another trial is ROP score, predicting tool in occurrence of the ROP based on birth weight, gestational age, and weight gain, and blood transfusion from the birth to 6th week of the life, and use of oxygen. Rainbow trial, which is ranibizumab, compared with the laser therapy for the treatment of infants born prematurely with the ROP, and the STOP ROP, which is supplement therapeutic oxygen for the pre-threshold ROP. Supplement O2 at plus at pulse oximetry saturation of 96 to 99 did not causes further progression of the pre-threshold ROP, which is suggested by the STOP ROP trial. Now, points to remember: establish ROP protocol based on current guidelines. Avoid delay in screening. First screening should be done before 30 days of life, which is 30 दिन रोशनी के slogan of the national guideline. Give clear education to parents regarding diagnosis, finding, follow-up, and treatment possibilities. Consent for screening and treatment and documentation according to National Operational Guideline 2018 as a medical legal record. This is a picture of the documentation of the ROP given by RBKS. Thank you.
Thank you very much, Tejal.
Thank you, sir.
That was a very lucid presentation. If I may, I can ask you a couple of questions. I think there have been some questions in the chat box. I think the first question was, do we have to screen all preterm babies less than 1200 grams irrespective of oxygen therapy? Certainly. I think the national guidelines, as you pointed out correctly, was less than 2000 grams. So anyone less than 2 kilos should undergo screening. 1200 grams certainly should undergo screening. Then there is another question was something regarding FiO2 guidelines, but that's okay. Ronak has asked this: are there any antenatal interventions to decrease the incidence of ROP? Tejal, do you want to answer that?
What is the question?
Are there any antenatal interventions to decrease the incidence of ROP? I think antenatal steroids are definitely one that has been mentioned that reduces the risk of ROP as well as lung disease and
ultimately prevention of prematurity is the primary prevention, and so that should be emphasized. And basically, many times we see obstetrician deliver a baby prematurely on some flimsy grounds. Leaking has started, and so let's deliver this baby. Now that is
said Amit. I would agree entirely. Lots of deliveries.
The other thing could be in utero transfer of the mother to a tertiary center, because a baby who is not resuscitated properly at birth at an obstetric center which doesn't have any facility for newborn, that is also a catastrophe in making, because such babies would be resuscitated by ill-trained or untrained people who would be giving 100% oxygen and a lot more resuscitation than required, and such baby will also end up having more ROP. So prevention of prematurity, antenatal transfer of this mother, in utero transfer of the baby, and then antenatal.
Thank you very much, Dr. Amit.
Sir, I would like to add one line. There's a term called as golden hour. That first golden hour, what sir just said, na, that is very important, because when the 100% oxygen is given in that time, that really increases the chances of treatable ROP in those babies.
Definitely. The question was antenatal factors.
So at delivery, obviously, there are a lot more interventions that we can offer. Antenatal questions, the question was about antenatal. So you have antenatal steroids and appropriate place of delivery for a premature infant. And Rekha, your point is well taken. Obviously, once the baby is delivered, optimal care has to be provided right from delivery. And that is why if the mother was antenatal transferred to a center which can look after these babies appropriately, that would be ideal.
Yeah, Dr. Anuj, there is one question on YouTube for Dr. Anand. Sir, invariably we are seeing that after dilating the eyes, there is apnea in newborns. So which are the ideal eye drops?
So I don't think it's that common at all, but there is a diluted version that's now commercially available. When during my residency, we used to actually take phenylephrine and dilute it 1:5 and then put it into a syringe, but now fortunately that's okay. There are at least 2 companies. In fact, one of them is from Gujarat, Opto Remedies, and the other one was the Arvind Eye Group has a drop. In fact, they call it ROP dilated drops. It's 2.5% phenylephrine with 0.5% cyclopentolate or 0.5% tropicamide with 0.5% cyclopentolate. There has been olden literature which has made people fearsome of paralytic ileus with cyclopentolate, but I think that's very anecdotal. Thousands or maybe lakhs of babies have got dilated, and that's not really something that we see at all clinically. Maybe in theory it can exist. The few precautions you have to take when the drop is put, you have to block the puncta so that you avoid systemic absorption. And from the skin also there's absorption. So one must dab the excessive drop coming and lying down or either on the cheek skin or on the face and so on. So these precautions should be, and minimal number of dilatation drops. Most of the time 2 drops are enough. Sometimes 3, and then the interval about 10-15 minutes. And I don't think you will see any complications with that.
Yes, Dr. Anuj. Yeah.
Okay. There's another question, use of erythropoietin and ROP, and there's a role of vitamin E in ROP.
I can answer these questions, and erythropoietin as such has no role in much of neonatology as well, so let alone in ROP. So not much of use. And second one was vitamin E. There's very standard indications for use of vitamin E, and all babies usually are on vitamin E supplementation nowadays with the guidelines. So no extra vitamin E has to be given for prevention of ROP.
Okay. And there's another question from Ronak. Is there any difference in the possibility of development of ROP for similar FiO2 exposure babies managed with invasive and non-invasive? So invasive ventilation versus non-invasive ventilation in the outcomes of ROP. Amit?
We can say that every time babies who are on non-invasive ventilator are definitely less sicker. So as opposed to baby who require invasive ventilation. So more sick babies have more likelihood of ROP. So we can say that babies who are only on CPAP would have lesser chances of ROP. But if you correct for gestation, if you correct for sepsis, there are no studies which have as such compared SIMB versus CPAP just for ROP.
Okay. You would expect babies who needed non-invasive, as you said, less sicker, so they should have lesser ROP.
And less premature also.
Okay. Dr. Anand, I had a couple of questions for you.
Yeah, me too. I also wanted to have this opportunity to ask Dr. Anand a couple of questions for benefit of the audience as well. Yes, sir. You begin first.
I'll start with the obvious question that everyone has on their minds is laser versus the anti-VEGF. What is your experience? Everywhere we see that laser is said as the gold standard, but yet I see that the anti-VEGF treatment use has going up steadily and laser use is going down steadily. So I would like to share your experience, please.
So undoubtedly, laser is still the gold standard. It has a very predictable outcome. It needs to be done properly, appropriately, and on time to get the success rates of up to 95 to 97%. Indian literature for ROP outcome is actually much better than the West. There have been theories on why that's so. pigmented retina, the close-up burns that we give, and so on. But then that's for another day. So I think laser is definitely something that gives a very predictable outcome. And for a zone 2, even a zone 2 posterior disease, there's nothing better than the injection. I mean, there's nothing better than laser. Now, why is anti-VEGF use going up? There are two reasons here. What we've been analyzing, the SNCUs across the country, when they started off, more than 700 plus of them, most of them, at least in many states, did not have ROP screening. And a lot of the oxygen was being given without, they didn't even have monitors to monitor that. So in Madhya Pradesh, in many states that was under the PHFI project, we were noticing, and of course in Karnataka as well, a lot of the SNCU babies were getting aggressive ROP. So if one has to decide where is that one place that injection might be considered over laser, it would be aggressive ROP. That old term of aggressive posterior has been changed to aggressive ROP only to indicate that aggressive disease can also happen anteriorly. So in our setting, in my own personal experience and all the other senior mentors of the country, what also Dr. Tejal mentioned as posterior zone 1. So that is popularly in India called zone half, where the blood vessels have not even reached the foveal center. So in such cases, trying out the laser and going all the way into the macula kind of doesn't make sense. It was okay 10 years back when we didn't have the injections and there was no other way to prevent blindness, then that was okay. But now the anti-VEGF is there. For zone half, we give the anti-VEGF, we follow it up. And, you have to understand that the anti-VEGF monotherapy, just giving one injection and the baby becoming completely all right, is less than 20%, even in Western literature. This means that 80% of babies after you inject will anyway require laser. The biggest question here is, when do you do that laser? Are you going to do it one day before, 1 week before, 1 month later? That is what we don't even have a proper guidelines, not in the Indian ROP Society, not in the Vitreoretinal Society, not anywhere abroad. And I think the reason is it's being customized. You have to see whether there's an early recurrence or a late recurrence. So obviously, if there's a recurrence, one has to go ahead and treat. And as Dr. Tejal mentioned, ranibizumab has earlier recurrences than bevacizumab. So bevacizumab recurrences are typically 3 to 4 months after the injection. Now, what is the problem with that? By then, the baby is about 5 or 6 kgs. By then, not many people are comfortable doing laser on such a big baby under topical anesthesia, which means now you will need the setup of general anesthesia or sedation, and that changes the whole scenario. If you are in a small center and you don't have a pediatric anesthetist, then it's a problem. So that's why people tend to laser much earlier after injections. Logically speaking, rationally speaking, the best time to do it is when the blood vessels have at least reached zone 2. So from zone half, if it's crossed zone 1 and gone to zone 2, then at least you've recovered some amount of retinal real estate, so to speak, where you don't have to laser that area because of vascularization. But if you inject today and laser tomorrow or next week, honestly, there is not a big advantage at all. There are centers that do that. And again, the reasons are maybe for follow-up. They feel that the child will not follow up, will go blind. So I might as well do something now rather than lose this baby and so on. But the most rational thing to do would be to follow up weekly till 40 post-menstrual age, 2 weekly till 48, 3 weekly to about 52 to 60. And if there is no recurrence, then at some point you have to do the laser for the persistent peripheral avascular retina. This term has come in the new classification. We were not familiar with it before. So the persistent peripheral avascular retina tells you that a good portion of maybe 30-40% of the retina is still avascular. You can't let it be like that. There are case reports of recurrences happening 2 and 3 years after injection. So you can't let this baby go out into the community if you have not taken care of the peripheral avascular retina. A long answer for a short question. So sorry.
No, thank you very much for that answer.
I have one related question, sir, for this. Such an important thing because it's actually increasing significantly about the choice of anti-VEGF to use because the cost varies significantly. Now, with use of Lucentin, they say it is it's a better drug, but there are not much data for neonatal ROP usage. And all the guidelines in NNF or AIMS guideline, they mention bevacizumab only, which is probably Avastin. So, and it is significantly cheaper as well. So what is your take on use of which anti-VEGF, and whether, affordability of patient also makes your choice that, okay, if it's a poor patient can't afford, then you use this. And if it's a rich patient who says, I want the best treatment for my child, then you use this. So what is your take on that?
So honestly, Avastin is the better drug. And I think world over everyone agrees. No, the ranibizumab has been used because it's been legally accepted. And now the biosimilar also under DGCI. And that is because the same company manufactures both. So they are never ever going to promote the cheaper drug when they can make more money selling the more expensive one. And we are familiar with this as ophthalmologists. The other reason why we say bevacizumab or Avastin is better is that it acts faster and the recurrences are fewer and later. Whereas in ranibizumab, the recurrences are much earlier and more frequent. And this has been seen all over the world. But unfortunately, because of the legal sanctity of the fact that one has got accepted for ocular use and the other one will never be accepted for ocular use, it's going to be a challenge every time that you decide to pick Avastin over bevacizumab, over ranibizumab. In our setting, 95% of babies receive Avastin. Whether they can afford the Lucentis or not, we still give Avastin because we do believe it's the better drug. We have the advantage of being in an institute setting. So the way the drug is aliquoted and the sterility which we use the Avastin drug is very good. And adults receive more than 50 to 100 injections of adult diabetic retinopathy and other conditions are given in the hospital. So for us to procure one injection, one syringe of Avastin for a baby is easy. But it's not so for a lot of outreach private practitioners who will have to buy one vial and open it out. And then what do? We have one baby to treat and I can make 10 or 12 injections from that one vial. That is the problem for Avastin. So if your ophthalmologist, if your ROP specialist has access to a safely prepared Avastin drug, please go ahead with it. It's absolutely safe. World over, it's been used a zillion times. There's enough data to show that it works very well. The only problem, and I repeat, the only problem is, can we assure the safety? Because a pre-filled syringe of, in fact, even ranibizumab doesn't come with a pre-filled syringe, but if the pre-filled syringe is the only advantage of the more expensive drug, and whereas this one, you have to manually prepare it under laminar flow or in a special setting and so on.
So bevacizumab is a safe drug to use for most units, and it is good enough for most circumstances.
It's more than good enough. It's more than good enough. The follow-up also becomes easier. The baby becomes much heavier and bigger by the time the blood vessels have reached zone 2. And it's not 650 grammer that you're injecting today and lasering it at 720 grams a couple of weeks later. So the whole clinical scenario changes when you give and we've had scenarios where some doctors in our periphery have run out of Avastin and very sadly then given ranibizumab and have noted that on the file. And we've had the opportunity to compare what happens with that eye injected with Avastin and with the same baby in the fellow eye with ranibizumab. Of course, there is going to be a cross transfer here systemically, so it's not the ideal way to decide. But even in such cases, we have seen that the Avastin eye does better than the ranibizumab eye.
Great. Thank you.
Can you please repeat the recurrence of Avastin versus laser?
The average recurrence for Avastin is 12 to 16 weeks, sir. And Lucentis is between 4 and 8 weeks.
And laser?
Laser shouldn't recur at all. Of course, in theory, the ETROP guidelines say it's about 9 to 12%. But in India, we have far better success rates. We have about 97, 98% success rate. And there are a few newer techniques that we follow in ROP laser, why we have such a good success rate. So earlier one had to laser only the avascular retina reaching up to the fibrovascular proliferation in stage 3. But nowadays we add at least 1 or 2 rows in front of the stage 3, what is called now a posterior laser, and then go back and fill up the gap after about 2 or 3 weeks. This not only gives an extremely flattened out, extremely good structural anatomical outcome, it has an excellent functional outcome years later, because we are able to reduce the incidence of myopia, because there is no more drag of the blood vessels, there's no narrowing of the arcade, there's no pushing of the fovea. Our myopic incidence from the time I was doing my residency, which is about 48%, is now about in single digits, 4 to 5%, and we're seeing it only in the very, very severe cases in extremely low birth weight, very premature babies.
And what are the
Incidence of myopia with the anti-VEGF?
It is claimed that it is less than laser. We beg to differ. I think there is enough Indian data to show that it's almost equal. If you follow up the injection with the laser, it's equal to any of those 3 groups. And I'll tell you why. Because when we give injection, one is we are cutting off the entire VEGF in the eye, which of course is the so-called villain, which is causing the ROP. But after some time, when the plus disease comes down and the disease goes away, you actually need that molecule for normal vascularization to take place to the rest of the retina. And that is why there is incomplete vessel growth to a particular point, because now you don't have any VEGF, because you've just killed the entire VEGF drive inside the eye. And that's why you need to laser. So as a result of that, as a consequence of that, you're getting retinal thinning. And when you get retinal thinning, and we've seen in the OCT studies, you actually get the axial length increasing, you get staphylomatous changes, and that is why you get high myopia even after anti-VEGF. So the incidences depend on which study which you read, but it's supposed to be in the single digits to about 15 to 20%.
So what would the rate of recurrence in Avastin, rate of recurrence?
The rate of recurrence, I don't know whether I can put a number on it, but I can definitely say that monotherapy will work in less than 20%.
Sir, I had a question. You said laser is better than these drugs. Is it only from in your centers, or it is across all Indian centers? So would the data differ across centers?
It's across centers, sir. I also added the caveat that if it was a posterior zone 1 or a zone 1 aggressive ROP, then I would also prefer an injection. So I think we are not saying that anti-VEGF is bad. In fact, it has a very important role for us to take care of children, especially the sick ones, and it definitely prevents blindness. I'm saying the indiscriminate use of anti-VEGF is a problem. I will tell you some unpleasant tasks I've had as Secretary of the Indian ROP Society is to sometimes audit certain cases. And I don't know if you've seen a very old Kamal Haasan film, which is actually a silent film, so it's hard to say in which language it was. He kills people, Pushpa Kabhimana. He kills his people with an ice knife. And the reason why he does that is then there is no evidence of a weapon, because it just melts. Unfortunately, anti-VEGF is like an ice knife. It doesn't leave any scar of laser. So if a badly done laser, anyone can point it out to the surgeon saying you've done a bad job, but not with an injection. And unfortunately, in our country, babies are getting injections when they don't need it. Some of them are getting injections when they may not even have ROP. And this is the sad fact that we have to accept. And especially with the coming of age with the medical legal cases, which Dr. Tejal also mentioned, we've actually published 6, we had a report on what we've learned from the 6 cases that went against doctors. 5 of them went against the neonatologist, and the 6th one went against the neonatologist and the ophthalmologist. And the landmark case that Tejal mentioned was 1.38 crores, 1.68 crores. So I think once imaging comes in, a lot of this is going to reduce. Because once you make imaging the gold standard of screening and not indirect ophthalmoscopy, then you as a neonatologist will be absolutely sure of what your ophthalmologist is writing on the file. I know how frustrated you all feel when an ophthalmologist walks in, writes stage 2, zone 1, whatever, and then says something and then goes off, and you have no clue how to validate that. Why? Because you all are on top of things with everything else. You all even do a cranial ultrasounds, you all do everything as neonatologists. But ROP is some place that you all feel you all are, your autonomy is lost. And I think that is coming back. In fact, the paradigm shift going in some countries, in some centers, is where pediatricians are going to start leading the screening program by imaging done by nurses. And there's a publication on that as well.
Thank you. Thank you.
So sometimes I see that ROP treatment is done as a two-step procedure. Two-step procedure, I mean that first anti-VEGF is put in, and then very rapidly within 2 weeks or so, a laser is asked for. Now that creates a problem for us. One is because of the costs involved. And because patient is already, he has spent about 3 weeks, 4 weeks in NICU, and then he has this laser injection and then his laser. So is it necessary to have this follow-up laser within, say, 2 weeks as well? I am more concerned about early lasers because till then the baby is inside NICU and I have to look after his expenses. Once he's at home, then it is his liberty to, to go to anyone and take another opinion. But biggest problem is in NICU and two-step treatment. So how often do you see this two-step treatment, very early laser after VGEF?
Sir, I completely sympathize with you. And I think this is what we were referring to, that this early laser after injection should not ideally be done. There should be reserved for those cases maybe where you think the baby will never come back from follow-up. Even that I doubt, because if you explain properly, they will. Now, combined therapy, as it is called, that is injection followed by laser, is an acceptable norm now, because as I mentioned, only maybe 20 to 30% will become all right with monotherapy. But as you rightly said, 2 weeks, 1 week, even 4 weeks is rather too early because we are not achieving anything. It's not for any other reason. We are not achieving anything. We are giving the injection because the disease was so posterior that by giving the laser now, we are going to run over the macula or the fovea, which kind of doesn't make sense. So now by giving the injection, you are promoting vascularization. You're reducing the plus disease. You're getting the flat neovascularization to regress. All of that takes time. The NVE, the plus comes down in few days, maybe even a week. But for the vessels to grow, and there are studies showing the rate of growth of these blood vessels, they take time. And for them to go from zone half to zone 2 will take anywhere between 6, 8, 12, or even 16 weeks. So I think there is absolutely no reason to go ahead and laser after 2 days, 1 week, and even 2 weeks. So you should put your foot down.
Yes, that's great.
I would like to add, sometimes either the ranibizumab, what is my experience is, there are few babies who develops a recurrence as 4 to 5 weeks. And if there is a recurrence, then we need to add up a laser at that point of time. So with ranibizumab, you can get an early recurrence at 4 to 5 weeks, and then you may need to add up the laser. With Avastin, there can be delayed recurrence, as sir mentioned.
Absolutely. So that's another reason why Avastin is probably preferred in the sicker babies, because you're also buying time. And definitely, as Dr. Rekha mentioned, I think if there's a recurrence, then there is no choice. Whether the recurrence happens early or late, you have to go and laser. It's the question of when they don't recur, but the vessels, you're just waiting for it to grow forward, then you can definitely wait.
So what about repeat injections? Answer. So evidence of repeat injections rather than doing the laser on the second occasion, if there's a recurrence?
I have never done it in my life. Okay. Repeat injection, never. First of all, giving the first injection only, we are so worried about the long-term developmental sequelae, which studies want to show you that they're very good, but sometimes the comorbidities and the confounding factors are so hard to pull out. A second injection, again, to me, doesn't make sense because you've already killed the VEGF drive. And for some reason, there's now a recurrence. Now you have to get rid of the avascular retina. By giving another anti-VEGF, you're going to further reduce the VEGF drive. So, on another note, we are doing some studies here in the hospital where we are taking the tears of these babies and assessing their VEGF values. And the VEGF at the very first screening, when they don't even have ROP, looking at the amount of VEGF they have in their tears, we're able to predict whether these babies will eventually get disease or not, or whether will require treatment or not. A part of it's been published, a part is under publication. Now, the reason why I say this is VEGF is so important. The babies who have higher VEGFs in their tears, remember, and this is supposed to be a surrogate marker for what's going on in the vitreous, they actually do not develop ROP later. Clearly tells you that this is actually a good molecule. You need VEGF for vascular growth. And the babies who had less VEGF in the very first screening, remember this is first screening when they didn't have any disease, they are the ones who are going to develop ROP. So, I mean, the rationale of giving a second injection is so counterintuitive because you already have killed the VEGF drive and now you're going to give another anti-VEGF drug. So no, never done it in my life.
Makes sense now. Thank you. You mentioned about the new classification of the ROP, the ICROP. I know you were part of the new classification. Can you just share as to what are the differences between the older classification and the newer classification?
Sure. Actually, I have a presentation, but we won't go there. So the main difference is, I would say, for clinically used, there's a lot that ophthalmologists will require to know. But just from our point of view, because the audience here is majority pediatrician, I think the aggressive ROP and the hybrid ROP has now got fused. So as I was mentioning, the aggressive posterior ROP tended one to believe that the disease can happen only in zone 1 or zone 2 posterior. Now we know, and this, a lot of the aggressive ROP data has come from our country and from middle income countries where we see this. So you mentioned something about, the outborn, and Rekha mentioned the golden hour. So a very typical case would be a baby born in a center where there is, I wouldn't like to comment, but let's say the neonatal care was not the best. So some amount of 100% oxygen was given, and the only reason was to keep the baby alive, which is a fair deal. Now, after that, the baby is transferred to a higher center where all the super monitoring happens. And then, as invariably, unfortunately, it happens, they can't afford that. So then they go back to another center, maybe slightly lower down. And you won't believe it, but you will actually see the pattern in the retina. You start seeing vasoconstriction, vasodilatation, vasoconstriction. So you'll actually see periods of time when you know that the neonatal care has gone from excellent to not so very good. So all of this causes capillary dropouts, causes NVE, even sometimes far out in the retina, that is very anterior. So now aggressive posterior ROP is now called aggressive ROP because we now recognize that all of these abnormalities that was earlier thought to be only existing around the macula can happen elsewhere. And there are 5 subtypes that have been described in the aggressive ROP. One is, of course, the classical AP-ROP, which we all are familiar with. But then the other ones are the very obliterated ones. These are the ones that do best with anti-VEGF because the vessels are so pencil thin that they've just come out of the optic disc and then that's it. They've not even gone up to the fovea. So there's no question of doing laser anywhere. Then there are other types where the hybrid ROP, which was described from our country first, but now that has got classified with the aggressive ROP. So if you see patterns of previously looking AP-ROP, but then also some areas of the classical stage 3, then that would be hybrid, but now you just give it the name of aggressive ROP. So that was the main thing. There's also a stage 5A, B, C, since Tejal mentioned 5. So now there's an A, B, and C, depending on the configuration, what you can see, and the anterior segment involvement. And then there's one more subtype, maybe from the exam point of view, this may be important, that in a stage 4, you also add the suffix E or T, which is exudative or tractional. Now, this is important for an ophthalmologist because tractional are the ones you might take up for surgery, and exudative you will either laser, inject, or just wait, and they might do better even without surgery. So that is one. The only thing that I was kind of making notes when Tejal was talking. So the one thing I want to clarify is that, Tejal, when you mentioned the first screening should be at the postmenstrual age of 32 or 4 weeks postnatal age, whichever is later. No, that is Western stuff. We don't follow that in our country. But then you went on and then clarified correctly when to screen, peace din roshni ke, fantastic. But that first slide that you had about when the first screening should be done should never be done because that's too late in our scenario. So if a baby is born at 25 weeks, you don't wait for 32 weeks or 4 weeks, whichever is later. If you want to say whichever is earlier, I'm still okay. But if you say whichever is later, by the time you screen this baby, the child will go blind. So in our country, 3rd week to 4th week, if it is less than 1200 grams, if it's more than 1200 grams with less than 2 kilos, and less than 1200 grams is between 2 weeks and 3 weeks. That's from the old NNF guidelines. If you can't remember that, it's okay. The first screening has to be done before day 30 of life. That's the only thing that you need to take back, and not the whichever is later bit. That's very risky.
Perfect, sir. I had also noted that point. The other thing which the presenter had said was when to screen is before discharge. So now that is also a very tricky issue, because if you say before discharge, then if baby is going at 2 weeks or even 10 days, do we have to screen it before discharge? Or because we can't have the fear that the baby will not be coming. My job is to absolutely pin into his brain that he has to come back. And he has to come back for so many things. And so we just can't do that, because one screening and the patient hears that normal eyes, he would never come back as well. Because that also gives him that safety jacket that okay, आँख तो ठीक थी, उसके बाद से कुछ हुआ भी नहीं, बच्चा भी ठीक है. So I don't agree with that point as well, that before discharge, or if there is a 1 or 2 day difference, like I have to screen on day 28, I am sending him on day 26. So I screen him on day 26. If I plan to screen a baby at 3 weeks and I'm sending him at 19 days or 20 days, I may screen him before sending him. But to say as a blanket statement that, before discharge, all babies should be screened, maybe a bit far-fetched.
I think it will depend on the gestation of the baby.
Yep.
I just want to react to that, sir. So obviously you run a very tight unit. You're very sure of patients coming back, but the average NICU across the country, and this has been published in Indian Pediatrics and then made its way into the guidelines for that one reason. Because when the early screening, the very early screening was compared with the classical timing of 3 to 4 weeks, 8 times more enrollment happened when we compared to hospitals, and both were government SNCUs in 2 different districts. And we published it in a pediatric journal just for the sake of the pediatricians to know that. So I think it's a safety net. If you can assure that the patient comes back for time, then there's absolutely no need to do the early screening. This has been done as a safety net because, and another reason what we noticed is that when you do the early screening, it's not just we communicate that it is normal. No, I don't think we should ever say normal until it reaches the ora serrata, the blood vessels. So what we have to tell them is this is immature retina, show them the picture, tell them, look, if this is 1 rupee, the blood vessels have reached only 30 paisa, another 70 paisa it has to grow. So please come back after 2 or 3 weeks. So the next visit can be proportionately longer and later compared to what you would have otherwise seen. Yeah, otherwise the reviewers, always felt that if you're screening a baby so early, aren't you sort of, this baby is too small to undergo screening. So no, systemic abnormalities did not happen. You can schedule the second visit a little later.
Sir, I'd like to add one point to the previous discussion about when to screen. So as sir mentioned, it has to be done between 2nd to 3rd week for less than 1200 grammars or less than 20. And for 1200 to 2 kg babies, the screening has to be done between 3rd to 4th. Now, there was another statement from Dr. Tejal that anyways, the treatable ROP doesn't come till 6 or 8 weeks post birth. That is not right. The screening guidelines have been made because we even have seen the treatable ROP at 3 weeks of life. So screening at the right time is very, very important so that we don't miss a baby at a treatable ROP stage. We have seen babies at 4 weeks, those who are less than 1200 grammars, those who have developed the stage 4. So timely screening is very, very, very important.
I would totally agree with Dr. Rekha that actually advice should be to screen at 3 weeks. The baseline advice, if there is one blanket week, it should be 3 weeks. And bigger babies can have it at 4 weeks, but not because if you plan at 3 weeks, then if he gets a bit late, that you still have that window. And sometimes ophthalmologist is not available, he is unwell or patient can't come over, he is just. So plan the unit policy should optimally be at 3 weeks, and most centers follow at 3 weeks. Some guidelines also say to follow at first at 3 weeks. So that gives you a window. If you somehow miss it, then you are no later than 4 weeks to be done. But AIMS protocols are very different, and I would like your opinion, Dr. Vindekar sir, that still under 1500 grams, it's blanket that all have to be screened. If you don't keep it under 1200 as Westerners say, and the issue is of larger babies who are between 34 and 36 weeks. Now, if you say above 34 weeks, any baby who requires oxygen more than 24 hours, any baby who requires prolonged ventilation, now, we never screened such babies earlier. Because meconium aspiration babies, he may remain on ventilator requiring nitric oxide, high frequency for a month maybe, but he was a 38 weeker. So what is your recommendation on these biggish babies who have required ventilation? Do they still require ROP, and do you see such babies developing ROP? And is there some genetic predisposition which can be tested? Because often we see twins, baby who was sicker doesn't get ROP, baby who required not even oxygen has advanced ROP.
True, sir. That's been an enigma too. So as far as the protocol concerned, I think that's the gray zone, and we would go strictly with the neonatologist decision. So less than 2 kilos, less than 34 weeks, some say IUGR and all of that. That I think is we should do. Now anything above that, now we get very routinely 2,200 grammars or 37 weekers suddenly coming in for ROP screening. And I think that the neonatologist has that gut feeling that it's not just about oxygen. It's probably about poor weight gain, maybe about the way the fluid management was. And there are 10 odd reasons why they would send the baby earlier. So we would not insist on screening these babies outside the criteria. If you just walk around the NICU saying, why not this one? We would only go with what the neonatologist says. I had this one nice formula that we discovered retrospectively and then we tested prospectively. And that is the weight gain that they have after they've lost their initial weight. In other words, every baby loses some birth weight and then regains it. Now, the number of days the baby takes to regain that weight can be actually used as a small formula. So in the study that we showed, if they regain their weight within about 7 to 10 days, in that cohort at least, none of them developed any ROP. And if they took more than 21 to 24 days, that was the range, then they invariably developed ROP, and about 50% of those required treatment. So the in-between one is the in-between one, where they probably developed some stage of ROP, but may not have required treatment. So just for y'all to know, because I know in the NICU files, y'all measure weight every day, if not every alternate day. And that's like a fairly decent indicator, because even before 21 days, before your ophthalmologist is called, you have a fair idea where this baby is going, but just based on the weight gain. And I'm not saying use this over any other criteria, but use this criteria also.
That suggests a major role for nutrition, early nutrition in the prevention of ROP.
Yes.
Okay. Another question I had for Dr. Anand. In the Western literature, most of the screening is recommended at less than 1,500 grams, while in Indian guidelines, it's less than 2,000 grams. Is there a genetic predisposition for increased ROP here, or is that the neonatal care is different?
No, it's just the variable neonatal care. It started off, I think, as 1750 in the 2010 guidelines of NNF. And then there was a gray zone in the 2010 guidelines, which said between 1750 and 2000, if the neonatologist felt so, and an N number of risk factors were mentioned, which is very gray zone. But now to prevent all that confusion, it's 2 kilos. As far as the genetic, no, there is no one gene that gets coded for ROP. But however, there is more and more recognition of an entity called ROPER, R-O-P-E-R, which is FEVR, familial exudative vitreoretinopathy, which is a phenotype just like ROP, but is seen in term babies, in which the blood vessels simply stop growing and develop ROP stages like in FEVR stages. So consanguinity is high in some communities and in some states like Karnataka and southern India. And we see a lot of these where it looks like FEVR, but it's seen in a preterm baby. Now, the importance of knowing the ROPER is that the outcome of treatment may not be as good as regular ROP. But no, there is no one gene discovered yet that can predict which baby will get into ROP.
I think there was a question on the chat about is screening at 2 to 4 weeks of age and less than 1,200 grams always feasible and safe if the child is still on cardiorespiratory support?
The short answer is yes, it is safe. We have actually, Dr. Dogra's group in PGI has shown how we can treat these babies when they are incubator and respiratory supported, when they are still inside the incubator, by just putting in 2 hands and doing the laser through the incubator wall, and that's been published. So, and we've done it on several occasions and the baby cannot even come out. My premise is if it is safe enough to treat a baby in the incubator when it is respiratory support is required, then definitely screening should be allowed. So even if you don't want to go prodding around and use the depressor and cause apnea and bradycardia, at least have a look at the central retina to look for whether the disease is in zone 1, look to see whether there's plus disease, look to see whether there's tunica vasculosa lentis. No one's asking you to be academically thorough to look, depress every quadrant to see if there's a stage 1 and zone 3 in these 6 babies. So I think the short answer is yes, it is safe.
Thank you. I think there was a mention about screening using a smartphone. Have you got any experience of that? Or, I mean, obviously you are using RedCam or something similar or indirect ophthalmoscopy, but there was mention from Tejal in her presentation about using smartphone.
Sure. So it can be used. We have the device. We've tried it out as well. There's a small learning curve. The main disadvantage of that is that it is limited by the 20 diopter lens. It takes a picture as wide as what we would see on indirect ophthalmoscope. So it is not a wide field image. Save that disadvantage or rather limitation. It's a good photo documentation. It may not serve as a telemedicine program. You won't be able to integrate it and keep follow-ups into it. But it serves as a good, fairly inexpensive tool to document what you're seeing. And medico-legally, it can save the doctor and the pediatrician. So I don't think it's a bad thing. The current resolution and the field is the limitation. And because it works pretty much just like how you would do an indirect ophthalmoscopy, it does require a skill. Therefore, as she also mentioned, it's kind of ophthalmologist dependent. But having said that, newer and newer models are coming, and I'm sure we'll see much more inexpensive models coming in the next 24 months.
Any other questions? I think there's a comment on use of role of nutrition in the development of ROP that we have already discussed. Human milk is protective. That was already mentioned in Tejal's presentation. So I think that was a very...
Viraj is there in a chat. Is there any role of anti-VEGF after laser?
So, well, in theory there is, and I've done it in one case, where actually I had gone to the rural area to do the laser. So we had carried only the laser with us. And probably that was a good, and we're talking about 2009 here. So injections were not that commonly used or even available. So I'd gone there and done the laser, and it was a very difficult laser, very tight, small pupil. And the week following, when we followed up, there was a lot of heme, vitreous hemorrhage, and couldn't do the supplement therapy that was ideally required after a week or 10 days. So we thought we'd lose the eye, and at that time anti-VEGF was just about coming. So we gave the Avastin at that time, and it did really well. The heme went away in 10 days, and then we got the gaps that we required to do the other, the remaining laser as well. So I think, yeah, you can juggle around, but if you're doing it for zone 1 ROP, then laser first and injection next doesn't make sense, because you're giving the injection because you don't want to do the laser so close to the macula. There are times when you will give the injection and operate. You'll give the injection, reduce the vascularity so that when you're doing the vitrectomy, it doesn't bleed intra-op. That's a very different setting. But doing the injection and doing the laser and then the injection, not sure. I mean, there can be situations like the one I mentioned, but may not be all the time.
ROP can we do, sir, in the 2nd or 4th or 5th day of life of child, newborn?
Pardon?
On 4th or 5th day of the life, can we do ROP examination?
Yes, I mean, there's no limit on when you can screen the baby as long as the baby tolerates the screening. In fact, the universal screening paper that we have, we were screening all these babies in the first 72 hours of life before discharge. These were, of course, term healthy babies to look at universal screening as a model. So there is no limitation on the age at which you can screen. You may not find the disease, But then there are distinct advantages of doing it early. And the most important one is you involve them in the ROP screening process, so the next follow-up becomes easy. As Dr. Amit mentioned, there are disadvantages of doing that in terms of the sickness and the costs involved. But at the community level, that's certainly a useful adjunct.
Because of it, in the periphery, the people are came once in a month. So we are going to 4/5 day of the life of preterm.
Correct. So exactly in those situations, an early screening is a good thing because you're not losing the baby for follow-up, and at least you're sure that the baby will come back having been counseled properly to come back.
Thank you.
I mean, your kid drop program would help in those situations if you have somebody in the periphery who could do the images. Is that what you follow in Karnataka?
Yes. So our team, we have 5 zones now. We have 5 cameras running every day in different NICUs across the state. We started off as 1 zone. So now we screen 127 NICUs, and the government wants us to add another 12 this year. And we are wondering whether that's possible. So yeah, so what happens is each team visits a few NICUs every day. And the images are uploaded on a telemedicine platform. But we've also trained these technicians to make the initial diagnosis so that the mother is given the diagnosis then and there, not waiting for the specialist to come back with the report. So there, as she mentioned, there can only be 3 outcomes: needs treatment, needs follow-up, or completely normal. And that's how we train everybody to make these, to take these images and do the reporting.
And I'm happy to share we have replicated the same model here in the Gujarat.
And she's doing an amazing job. And we're very, very proud of Rekha's work.
Dr. Vindekar has been doing something similar in Ahmedabad as well.
In Surat, sir. We are doing whole of the South Gujarat, sir, here. From Bharuch till the Vapi, sir, we are covering.
Can we look at using NNF's platform to extend it across Gujarat? I think we can discuss this, not now, but offline, but I think we should look at doing this across Gujarat. Maybe Dr. Sandeep and Dr. Prashant can.
Yes, sir. Gujarat government also going to plan one ROP screening and each district place, because of the Utpal Jani is from the Kheda ophthalmologist is the in charge of that program, and I also talked with him, and they are going to plan for ROP screening in whole Gujarat in each and every newborn particular.
I think we should have a good program. I think we should talk to Dr. Rekha more often so she can share her experience. Dr. Amit wanted to say something.
Yeah, sir, we will definitely. And I think, Dr. Anuj, if there are no questions, we overshoot the time.
We have overshot the time by almost half an hour. So,
but it always happens when Dr. Anand is there. So everybody wants to listen. And we are really thankful that in spite of having so many appointments of surgery, today is surgery day. Still he joined from the very beginning only.
Maybe we should have another session on ROP separately for 1 hour.
Yeah, from him only the presentation.
Yes,
not
yes.
as expert.
I'd be happy to do that. Thank you. And our program is a success in Karnataka only because of NNF. So you guys are doing a great job, and please continue to do that and help the fellow ophthalmologists to take it up further. Thank you so much.
Sure.
Thank you so much.
So on behalf of NNF Gujarat, we present a certificate of appreciation to Dr. Tejal for presenting a PG seminar and giving all the details. We are also thankful to Dr. Anand Vindekar sir for being expert, as well as Dr. Amit Upadhyay sir for being expert. And thank you to Dr. Anuj Grover for being a chairperson in today's Neonatal Pathshala. So those who are there still after 4:30 also, and we are having Neonatal Pathshala every Wednesday at 3:30 p.m. We start by 3:30 and try to finish in 1 hour. But as today was a topic of hot discussion, we start